what do we mean by general anesthetics? As the term described, by general anesthetics, the drugs basically they produce reversible loss of all sensation and consciousness. They are generally used prior to any surgical procedure so that the patient does not feel the pain and are amnesic about the incident. What are the cardinal features of general anesthesia? Number one, loss of all sensation, particularly pain. Mobile ta pore dekho. Please see the mobile later on. The cardinal features of general anesthesia, number one, loss of all sensation, particularly pain. Number two, immobility and muscle relaxation. And lastly, abolition of somatic and autonomic reflexes. Now, in the modern practice of balanced anesthesia, what do we mean by balanced anesthesia? Basically, use of more than two or more than two anesthetic agents, so that the individual anesthetic agent is required in a lesser amount and their side effects can be decreased. So, in the modern era of balanced anesthesia, these modalities can be achieved by combination of inhaled and intravenous drug, each drug for a specific purpose. General anesthetic agents basically they are inhalational and they are intravenous. Some inhalational general anesthetic agents are available like ether, nitrous oxide, halothane, enflurane, isoflurane. Similarly, some intravenous and GA are available like benzodiazepines, ketamine and others. So, history of general anesthesia. Before the middle of 19th century, a number of agents like alcohol, like opium, cannabis or even concussion and hypoxia, patients were deliberately hit in the head so that patient become unconscious and are not does not feel the pain. So, even concussion and asphyxia were used to obtain surgical pain, but the operations were horrible ordeals. It was in the middle of the 19th century. First, the Horace Wills, he was a dentist and he used the idea of using nitrous oxide from the demonstration of laughing gas in 1844. However, he failed to relieve the dental pain completely. Now, Morton, a dentist and the medical student at Boston, after experimenting on animals, they gave a demonstration of ether anesthesia in 1846. The photograph of showing demonstration of ether anesthesia is there in the pharmacological department. So, it was done by Morton and it soon became very popular. It was a remarkable discovery. Now, chloroform was used by Simpson in Britain for obstetrical purpose in 1847, but because of toxicity, it is basically not that used. Cyclopropane was introduced in 1925, but the new generation of anesthetic like halothane in 1956. The first intravenous anesthetic thiopenton was introduced in 1935. It's a basically barbiturate, ultra short acting barbiturate. Now, mechanism of general anesthesia, mechanism not precisely known. A wide variety of chemical agents are available as general anesthetic. They are diverse molecules acting via different mechanisms. Mayer and Overton pointed out a direct parallelism between the lipid water partition coefficient and of the GA and their anesthetic potency. It has been seen that depending on the lipid water partition coefficient, the solubility of the drug in the blood varies and that can account for the anesthetic potency. So, to measure the potency of inhalational general anesthetic, we use minimal alveolar concentration, MAC. What do we mean by MAC or minimal alveolar concentration? Is the concentration of the inhalational general anesthetic in the pulmonary alveoli needed to produce immobility in 50% of the individual to a painful stimulus. What do we mean by minimum alveolar concentration? Is a measure of potency of the inhalational general anesthetic, defined as the concentration of the drug needed in the pulmonary alveoli to produce immobility in 50% of the individual to a painful surgical stimulus. Okay. It is accepted as a valid measure of potency of inhalational general anesthetic. Why? Because it remains fairly constant through all age groups, basically in most of the young adults. The MAC of all inhalational anesthetics decline progressively as the age advances beyond 50 years. 50 বছরের পর কিন্তু MAC খুব একটা valid potency measure নয়. Now, the MAC of a number of GA show excellent correlation with the oil gas partition coefficient. However, this only reflects the capacity of the drug to reach the CNS and attain sufficient concentration in the neuronal membrane, but it does not explain the mechanism of the drug, mechanism of action of the drug. So, unitary hypothesis was previously propounded that some single common molecular mechanism is responsible for the action of all inhalational anesthetics that has been superseded by the agent specific theory, which basically says different GA produce anesthesia by different mechanism. প্রত্যেকটা anesthetic drug এ নিজস্ব mechanism রয়েছে. Now, recent evidence favors a direct interaction of GA molecules with the hydrophobic domains of the membrane protein or lipid protein interface. Now, not only different anesthetic produce the action by a different mechanism, there are also stereo specific effect. The stereoisomer of the drug, the action may vary. So, and that various component of the anesthetic state may involve action at discrete loci in the cerebrospinal axis. Now, the general anesthetic drug, they produce unconsciousness by acting in the thalamus or in the reticular activating system. They produce amnesia by action at the cerebral cortex and the hippocampus. They produce immobility via action on the spinal cord. The recent theory has suggested that the ligand-gated cation channels, ligand-gated ion channels are the major target of action of general anesthetics than the voltage-gated channels, and the major action and the most of the action occurs at the GABA A receptor-gated chloride channel. It is the most important site of action of the general anesthetic drug. Now, many inhalational anesthetics, barbiturates, benzodiazepines, propofol, they potentiate the action of GABA on the chloride channel, in the GABA receptor gated chloride channel. Each of the above anesthetics, they appear to interact with its own specific binding site. GABA gated chloride channel, the different anesthetics, they bind at different site and they potentiate GABA action on the chloride channel. But none bind to the GABA binding site except some inhaled anesthetics and barbiturate. Now, is the one action GABA gated chloride channel. Number 2 is on the glycine. Action on glycine, another inhibitory transmitter which also activate the chloride channel in the spinal cord and medulla and are responsible for the immobility in the anesthetized state. Now, the third, certain fluorinated anesthetic and barbiturates, they inhibit the neuronal cation channel gated by nicotinic cholinergic receptor mediating analgesia and amnesia. And N2O and ketamine, nitrous oxide and ketamine, they act on the NMDA type of glutamate receptor. And what does they cause? basically glutamate receptor, they are basically ligand gated calcium specific channel. So basically they inhibit the excitatory NMDA type of glutamate receptor, so that inhibition of which appears to be the primary action of anesthesia of ketamine and N2O. Basically calcium influx is inhibited, neuronal hyperpolarization is decreased, and thus they are accounting for anesthesia. Neuronal hyperpolarization can basically caused by the general anesthesia can also be done by activation of a specific type of potassium channel called 2-pore domain channel. Basically 2-pore domain channel, they cause activation of which cause inhibition of number 1 pre-synaptic transmitter release and number 2 post-synaptic activation. Transmitter release টাকে inhibit করছে and post-synaptic activation টাকে inhibit করছে via action on the 2-pore domain channel. Now, inhibition of transmitter release from presynaptic neuron are related to also interaction with certain critical synaptic proteins. Now, local anesthetics, they are basically blocking axonal conduction, but general anesthesia, they are blocking synaptic transmission. There is a major difference of action between the local anesthetics and the general anesthesia. Now, stages of anesthesia. Now, previously, before the advent of the modern general anesthetic drugs, ether was very commonly used in anesthesia, and it was Goodell who described 4 stages of ether anesthesia. Now, before going to that, general anesthesia, they cause descending type of basically CNS depression, and that is irregular. Mane, in the brain higher functions are basically depressed first, followed by the lower areas of brain. Then in case of spinal cord, lower segments are paralyzed first, followed by the higher segments, and it is the medulla oblongata containing the vital centers. So the vital centers located in the medulla are paralyzed the last as the depth of anesthesia decreases. Now, it was Goodell in 1920 who described 4 stages of depth of anesthesia attained by ether: stage 1, stage 2, stage 3 and stage 4, as the depth of anesthesia is increased due to increasing concentration of ether. Now, the stage 3 has been again divided into 4 planes: plane 1, plane 2, plane 3, plane 4. Now, stage 1 is called stage of analgesia. The precise sequence of event differs somewhat with anesthetics other than ether. Now, stage 1, that is the stage of analgesia. As the name suggests, here the pain response is abolished. It starts from the beginning of the anesthetic inhalation and lasts till the loss of consciousness. Pain is progressively abolished. Patient remain conscious throughout the stage 1 of ether anesthesia, can hear and see and feels a dream-like state. Amnesia develop by the end of this stage. So patient যখন থেকে anesthesia দেওয়া আরম্ভ হলো till the loss of consciousness is occurring, that is stage 1, stage of analgesia. In this stage, patient remains conscious, can hear and see, and the pain is progressively abolished. Reflexes and respiration remain normal. This stage is ideal for carrying out minor and short operative procedures, but rather difficult to maintain. Number 2, stage of delirium. প্রথমটা ছিল stage of amnesia, analgesia, sorry. Number 2 is stage of delirium. It starts from the loss of consciousness to the beginning of the regular respiration. ঠিক আছে? What happens here? Apparent excitement is seen. Sympathetic stimulation এ যা যা features থাকবে এখানে দেখা যাবে। Heart rate, blood pressure rise করবে, পেশেন্টের ব্রিদিংটা জার্কি ইররেগুলার হয়ে যাবে, তার সঙ্গে পেশেন্ট মে শাউট, স্ট্রাগল অ্যান্ড হোল্ড হিজ ব্রেথ, মাসল টোন উইল ইনক্রিজ, jaws are tightly closed, breathing is jerky, and pupil dilate due to sympathetic stimulation. Okay, so no stimulus should be carried out or applied, or no operative procedure should be carried out during this stage. This stage is inconspicuous in modern anesthesia. এই স্টেজ 2 or স্টেজ অফ ডেলিরিয়ামে কোনো অপারেটিভ প্রসিডিউর করা যাবে না, পেশেন্ট এমনিও কিন্তু খুব এক্সাইটেড থাকে সেই স্টেজে। Number 3 is surgical anesthesia. Most of the operations are carried out in this stage, stage 3 plane 1. Okay, so it extends from the onset of regular breathing to cessation of the regular respiration or spontaneous breathing. This stage has been divided into 4 planes: plane 1, plane 2, plane 3, plane 4. What do we mean by plane 1? Here the eyeball roving is there. This plane ends when the eyes become fixed. Plane 2, loss of corneal and laryngeal reflexes. Plane 3, pupil starts dilating and light reflex is lost. And plane 4, intercostal paralysis, shallow abdominal respiration, dilated pupil. So as the plane is increasing, plane 1 to plane 4, abdominal type of respiration is taking over the thoracic type of respiration due to intercostal paralysis. As anesthesia passes to deeper planes progressively, muscle tone decreased, blood pressure falls, heart rate is increased with weak pulse, respiration decreases in depth and later in frequency as well. Thoracic respiration lags behind the abdominal respiration. ঠিক আছে? And number 4, the last stage, that is medullary paralysis. Now it basically continues from the cessation of breathing to failure of circulation and finally death. So pupils is widely dilated, muscles are totally flabby, pulse is thready or imperceptible, and blood pressure is very low. Really, anesthetists, they do not try to avoid stage 4 and they basically prefer stage 3. So this is stage 1 where the thoracic and abdominal type of respirations are there. It's regular respiration, ocular movements are normal, pupil size is normal, reflexes are normal, tone of muscle is normal, blood pressure, heart rate is একই থাকে. It is used in labor incisions and minor operation. And stage 2, that is stage of delirium. Here the abdomen respiration becomes jerky and irregular. The roving eyeballs are start from here. Pupil size is increased due to sympathetic stimulation, and then muscle tone is increased, heart rate, blood pressure may rise. Generally, we do not carry out any operation in this stage. Now coming to the stage 3 of surgical anesthesia, plane 1, 2, 3, 4. As the plane progresses, the respiration cessation start to begin. In the plane 1 there is roving eyeballs, eye becomes fixed at the end of plane 1 and the eyes are fixed. As the basically plane progresses, pupil size is increased, the reflexes start to abolish, muscle tone start decreasing, heart BP basically tends to fall as the plane progressed and heart rate rise. Most of the surgical operations being carried out in stage 3 plane 1. Stage 3 occasionally reached now, stage 4 never attempted. And stage 4 medullary paralysis, basically dilated pupil and respiration, spontaneous breathing is not there. Many of the above indices of anesthesia have been obscured with the use of fast acting anesthetics, pre-medication and muscle relaxant. এখন যে ব্যালেন্স অ্যানেস্থেসিয়া চলে, যেখানে মোর দ্যান ওয়ান অ্যানেস্থেটিক ড্রাগ ইউজ করা হয়, এই টিপিক্যাল ডিভিশন অফ দি স্টেজেস অফ অ্যানেস্থেসিয়া ইজ নট ফাউন্ড. The modern anesthetics has to depend on several other observations to gauge the depth of anesthesia. তো depth of anesthesia বোঝার জন্য তারা আরো কিছু ফিচার্স মাথায় রাখে, লাইক If eyelash reflex is present and the patient is making swallowing movement, that means patient is in stage 1 and stage 2 has not been reached. Number 2, loss of response to painful stimulus. For example, pressure on the upper nasal orbit of the upper nasal border of the orbit. That means stage 3 has been achieved. Incision of skin causes reflex increase in respiration, BP rise or other effects. Insertion of endotracheal tube is resisted and induces coughing, vomiting, laryngospasm. Tears appear in the eye on surgical incision. Passive inflation of lung is resisted. That signifies that the anesthesia is light and has to be deepened. Fall in blood pressure, cardiac and respiratory depression are signs of deep anesthesia. Now, in the present day practice, anesthesia is generally kept light. Adequate analgesia, amnesia and muscle relaxation are produced by the use of intravenous drugs. Pre-medication, pre-medication মানে কি? Anesthesia দেওয়ার আগে কিছু কিছু ড্রাগ ব্যবহার করা হয় so that it facilitate the induction and of anesthesia. So pre-medication with CNS depressants and opioids or their concurrent use, they lowers the minimum alveolar concentration of the inhaled anesthetic. When a combination of two inhalational anesthetic is used like nitrous oxide, isoflurane, their MACs are additive and lower concentration of each is required. For example, we are using A and B. These are the two inhalation anesthetics. Now, A has got one MAC and B has got another MAC. Now, if we are combining the drug, so if A has got 1 and B has got 2 MAC, 1 plus 2, 3, the MAC becomes 3. So, basically they are additive. So, we can use, if one amount of drug was used, if we can use half amount of drug if the two drugs are combined. So, what happens? The same depth of anesthesia is reached with lesser amount of the drug, individual drug. So, the side effects of the drug can be decreased. This is a basically principle for balanced anesthesia. When a combination of two inhalational anesthetics is used, their MACs are additive and lower concentration of each is required. The dose response relation of the inhaled anesthetic is very steep. Just 30% higher of MAC, that is 1.3 MAC, immobilizes 95% of the subject. Mane basically 1 MAC te 50% of the subject immobilized হচ্ছিল. Now with 1.3 MAC, 95% of the subjects are immobilized. Concentration of inhalation anesthetics exceeding 1.5 MAC are rarely used and 2 to 3 MAC is often lethal. Anesthetized subjects generally wake up when anesthetic concentration falls to 0.4 MAC. Now coming to effects common to inhalational anesthetics. The EEG initially shows activation with the use of inhalational anesthetics, but as the concentration is increased, there is progressive EEG suppression culminating in electrical silence at more than 2 MAC. Decrease in cerebral metabolic rate. As the inhalation anesthetic is given, the cerebral metabolic rate will decrease. Now, it directly reduces the cerebral blood flow. However, at the higher depth of anesthesia or at higher concentration, their direct vasodilatory action can cause cerebral vasodilatation and hence the cerebral blood flow may increase with the higher concentration of the drug. This higher concentration should be avoided in patients of raised intracranial tension. All fluorinated anesthetics depress cardiac contractility and lowers the blood pressure. Respiratory depression, bronchodilation and reduced airway mucociliary function occurs so that prolonged anesthesia can cause respiratory complications. কি হবে? aspiration pneumonia due to respiratory depression, bronchodilation and reduced airway mucociliary function. Limited and reversible lowering of glomerular filtration rate and urine volume may occur. There is reduced gastrointestinal motility. Now, pharmacokinetics. Inhalational anesthetics are gases or vapors that diffuses rapidly from the pulmonary alveoli to the blood to the tissues and they goes to the brain. The depth of anesthesia depend on two factors. Number one is MAC or practically potency of the agent and the partial pressure of the drug in the brain, and the induction and recovery they depend on change of rate of change or partial pressure of the drug in the brain. So, the depth of anesthesia depend on the MAC of the drug or the potency of the drug. Number two, partial pressure of the drug in the brain, and the induction mane ki how quickly we are attaining the effect with the general anesthetic. So, the induction and the recovery depend on the rate of change of partial pressure in the brain. Now, transfer of the anesthetic between the lung and the brain depend on a series of tissue gradient. আমরা যখন ড্রাগটা দেব প্রথমে এয়ারওয়ে ট্র্যাক দিয়ে পালমোনারি অ্যালভিওলাইতে যাবে, পালমোনারি অ্যালভিওলাই থেকে ব্লাডে মিশবে ক্যাপিলারিজে, সেখান দিয়ে আবার ব্রেনে যাবে, ওখান দিয়ে আবার টিস্যু গ্রেডিয়েন্ট রয়েছে। সো অ্যালভিওলাই টু ব্লাড টু ব্রেন and vice versa. Factors affecting partial pressure of the anesthetic attained in brain. Number one, partial pressure of anesthetic in the inspired air. যতটা বেশি partial pressure থাকবে ততটা বেশি বেসিক্যালি ব্লাডে যাবে আর ব্রেনে যাবে। তো partial pressure of anesthetic in the inspired gas, pulmonary ventilation, alveolar exchange, solubility of the anesthetic in the blood and in the tissues, and lastly the cerebral blood flow. Partial pressure of the anesthetic in the inspired gas, this is proportional to its concentration in the inspired gas mixture. Inspired gas mixture e jotota concentration থাকবে ততটা partial pressure বেশি থাকবে. Now, higher the inspired tension, more anesthetic will be transferred to the blood. যতটা বেশি partial pressure থাকবে, more will be the tension in the inspired gas and rapidly the drug will be infused in the blood. Thus, the induction can be hastened by administering the drug at higher concentration in the beginning. So, induction can be made fast by increasing the concentration of the drug. Number two, pulmonary ventilation. It governs the delivery of the general anesthetic to the alveoli. Now, hyperventilation, যে পেশেন্টটা hyperventilate করছে কি হবে? More will be the minute volume. So, hyperventilation will bring in more anesthetic per drug and respiratory depression will have the opposite effect. Influence of minute volume on the rate of induction is greatest in case of agents having high blood solubility. এটা পরে আসছি আমরা. However, it does not affect the terminal depth of anesthesia. Alveolar exchange. The general anesthetic diffuse freely across alveoli, but if alveolar ventilation and perfusion is mismatched, then what will happen, like in case of patients of emphysema in lung disease, then what will happen? The attainment of equilibrium between the alveoli and the blood is delayed. কি হবে? For example, say the alveoli is well ventilated, the alveoli is well perfused but less ventilated, then what will happen? Basically, less drug will be reaching the blood, there will be lesser concentration of the drug in the blood, and oppositely, if the alveoli is normally functioning, there the blood will have normal concentration of the drug. Now, what will happen? This the blood from the mismatched ventilation perfusion alveoli will dilute the drug in the normal alveoli, and hence the induction and recovery both are slowed. So, in case of ventilation perfusion mismatch in different lung conditions, the induction and recovery of general anesthesia may be slowed. Solubility of anesthetic in the blood. This is the most important property determining induction and recovery. Large amount of an anesthetic that is highly soluble in blood like ether must dissolve before the partial pressure is raised. So একটা ব্লাডের বেসিক্যালি অ্যানেস্থেটিক গ্যাসের পার্শিয়াল প্রেসার বাড়াতে গেলে প্রথমে কিন্তু যে ড্রাগটা সলিবলাইজ ফর্মে থাকবে ড্রাগটা সেটা পুরোটা স্যাচুরেট করতে হবে, তারপরে গ্র্যাজুয়ালি পার্শিয়াল প্রেসারটা বাড়তে আরম্ভ করবে। দ্য ড্রাগ উইল বি ইন দ্য ফ্রি ফর্ম। So large amount of an anesthetic that is highly soluble in blood must dissolve before its partial pressure is raised. The rise and fall of partial pressure in blood and consequently induction and recovery are slow. For which drug? Drugs having high blood solubility. যাদের blood solubility high থাকবে তাদের কিন্তু partial pressure rise করতে time লাগবে, so induction and recovery will be slow. Drugs with low blood solubility like nitrous oxide, isoflurane, sevoflurane, desflurane, they induce quickly and are recovered quickly. Blood gas partition coefficient given by the ratio of concentration of anesthetic in blood to that in gas phase is the measure of solubility of anesthetic in the blood. ঠিক আছে? Now this was about the solubility of the anesthetic in the blood. Next comes the solubility of anesthetic in the tissues. Relative solubility of anesthetic in blood and tissue determines its concentration in that tissue at equilibrium. Now most of the general anesthetics are equally soluble in the blood and in the lean tissues, but more soluble in the fatty tissues, and again the fatty tissues have low blood supply. So if the drug is highly lipid soluble like halothane, what will happen? More and more drug will be deposited in the adipose tissue as the concentration of drug is increased, and will be released slowly as the blood supply is poor there. So anesthetics with higher lipid solubility like halothane, they continue to enter adipose tissue for hours and also leave it slowly. So what will happen? Induction will be slow and recovery will be slow. The concentration of these agents is much higher in white matter than in grey matter. Now cerebral blood flow. Brain is highly perfused organ and general anesthetics are quickly delivered to it. Now this can be hastened by carbon dioxide inhalation. Why? Because number one thing, carbon dioxide inhalation will cause cerebral vasodilatation, and that will increase the delivery of the drug to the brain. And number two, CO2 inhalation may stimulate respiration, and that will hasten delivery of drug to the brain. Now elimination, এগুলো হলো ইন্ডাকশন রিকভারি উপরে। এখন যখন ড্রাগটা ডিসকন্টিনিউ করব তখন ড্রাগটা বডি থেকে বের হবে। হাউ দ্য এলিমিনেশন আকার্স? The pathway by which the drug is taken up in the body is reversed during elimination. So for all inhalational anesthetic agents, the primary route of elimination is the lung. When inhalation of anesthetic is discontinued, gradients are reversed and the channel of absorption becomes the channel of elimination. All inhaled anesthetics are eliminated mainly through the lungs. The same factors which govern induction and recovery also govern recovery. Anesthetics in general continue to enter and persist for long periods in adipose tissue because of high lipid solubility and low blood flow. So most of the general anesthetics, they are highly lipid soluble, they deposit in the adipose tissue. The second is they also get deposit in the muscles. So muscles occupy an intermediate position between the brain and the adipose tissue. Most general anesthetics, they are eliminated unchanged except halothane, which is more than 20% metabolized in the liver. Recovery may be delayed after prolonged anesthesia, especially in case of more lipid soluble anesthetics. Now second, gas effect and basically diffusion hypoxia. Now in the initial part of induction, diffusion gradient from alveoli to blood is high and larger quantity of anesthetic is entering blood. যখনই আমরা anesthesia, inhalational anesthesia দিতে আরম্ভ করব, the concentration of the drug in the inspired air is very high compared to the concentration of drug in the present in the pulmonary alveoli. So what will happen? More amount of the drug is sucked in because of the concentration gradient. ঠিক আছে, ড্রাগটা যেটা আমরা দিতে আরম্ভ করলাম নাক দিয়ে, এটা তো কনসেন্ট্রেশন ভেরি হাই আছে ড্রাগের compared to the air present in the pulmonary alveoli initially. So there is very steep concentration gradient and the drug will be sucked in. Now what happens if we administer the drug in very high concentration, like in case of nitrous oxide, the drug is administered at a concentration of 70 to 80%. So if the inhaled concentration of anesthetic is high, what will happen? Substantial loss of alveolar gas volume will occur and the gas mixture will be sucked in. আমরা যতটা concentration বাড়াবো ততটা কিন্তু gas mixture তাড়াতাড়ি suck in হবে and it will displace the alveolar air. Independent of the ventilatory exchange, gas flow will be higher than the tidal volume. For example, যদি tidal volume টা থাকে 1 liter per minute, extra additional more than the tidal volume, the drug will be delivered. So this is significant only with nitrous oxide since it is given at a concentration of 70 to 80%. Now what happens if we are administering nitrous oxide at a concentration of 70 to 80% and we also deliver another inhalational anesthetic agent the same time like isoflurane. So isoflurane is given at a lower concentration, only nitrous oxide is given at a higher concentration. Now when nitrous oxide is given, what will happen? It will displace the alveolar air quickly. Along with that, it will also carry isoflurane with it. So the rate of induction of isoflurane will become faster if it is administered with nitrous oxide. So though it has low solubility in blood, about 1 liter per minute of N2O enters the blood in first few minutes. As such, gas flow is 1 liter per minute higher than the minute volume. If another potent anesthetic agent like halothane is given at the same time, it will also be delivered to the blood at the same rate, that is 1 liter per minute higher than the minute volume, and the induction will be faster. This is called second gas effect. So if a lower concentration of a potent anesthetic agent is administered simultaneously with a inhalational agent at very high concentration, then the rate of induction with the first agent will be faster. The reverse occurs when N2O is discontinued after prolonged anesthesia. N2O দিচ্ছি আমরা, কাজ হয়ে গেছে, এখন N2O discontinue করলাম, তাহলে কি হবে? N2O having low blood solubility, it rapidly diffuses into the alveoli. Blood এর মধ্যে রয়েছে, যখন discontinue করলাম, it has got low blood solubility, so it will be rapidly going to the alveoli and will displace the alveolar air. So there will be a relative hypoxia instantaneously. Now and the partial pressure of oxygen in the alveoli is reduced. The resulting hypoxia, called diffusion hypoxia, is not of much consequence if the cardiorespiratory reserve of a person is normal, but in lung conditions or heart conditions it can be low and that can be significant. How can it be minimized? By giving the patient 100% oxygen for a few minutes after discontinuing N2O. So diffusion hypoxia can be prevented by continuing 100% oxygen inhalation for a few minutes after discontinuing N2O instead of straight away switching over to air. Diffusion hypoxia is not significant with other anesthetics. Now properties of an ideal anesthetic. আমরা কোন anesthetic সবথেকে বেশি প্রিফার করব? For the patient, it should be pleasant, like ether, very irritant, pungent odor. So it should be pleasant, non-irritating, should not cause nausea or vomiting. Induction and recovery should be fast with no other effects. Okay. For the surgeon, it should provide adequate analgesia, immobility and muscle relaxation. It should be non-inflammable because cautery may be used in that case. So, it should be non-inflammable and non-explosive so that cautery can be used. For the anesthetist, its administration should be easy, controllable and versatile. Margin of safety should be high, no fall in blood pressure. Heart, liver and other organs should not be affected with the drug. It should be potent so that low concentration are needed and and oxygenation of the patient does not suffer. Rapid adjustment in the depth of anesthesia should be possible. It should be cheap, stable and easily stored, and it should not react with the rubber tubing and soda lime. So, basically the pharmacokinetic properties of different inhalational anesthetics. Halothane having the highest oil gas partition coefficient, and the list is for the nitrous oxide, the same for the blood gas partition coefficient. The induction is faster with desflurane, sevoflurane, nitrous oxide, slow with ether. Now coming to pre-anesthetic medication. What do we mean by pre-anesthetic medication? These are the use of drugs other than the anesthetic agent prior to anesthesia, so that anesthesia basically induction can be made smooth and other complications can be prevented. So, pre-anesthetic medication refers to the use of drugs before anesthesia to make it safe and less unpleasant. What are the aims of pre-anesthetic medication? Number one, relief of anxiety and apprehension pre-operatively and to facilitate smooth induction. Number two, amnesia. Patient should not be aware what is being done. Amnesia for peri-operative events, analgesic action of the anesthetics and potentiate it so that less anesthetic is needed, lesser side effect. Decrease in secretion and vagal stimulation that may be caused by anesthetic agent. Antiemetic effect extending into the post-operative period. Decrease acidity and volume of gastric acid so that the aspiration and aspiration pneumonia can be prevented, and if they are less damaging. Now, what are the drugs used in the pre-anesthetic medication? Number one is sedative anti-anxiety drugs, more commonly used. Benzodiazepines like diazepam or lorazepam, they are used for pre-anesthetic medication. Advantage, number one, because of tranquility they produce smooth induction. There is loss of recall of perioperative events, little respiratory depression unlike opioids, and action and basically decrease the post-operative vomiting. They counteract CNS toxicity of local anesthetics. Now, used along with opioids for a variety of minor surgical and endoscopic procedures. Midazolam is a good amnesic with potent and shorter lasting action, used intravenously and due to water solubility. Promethazine, antihistaminic with sedative and antiemetic and anticholinergic property, causes respiratory depression. Opioids like morphine, pethidine, they allay anxiety and apprehension before the procedure, and they cause pre and post operative analgesia, smoothen induction and reduces the dose of anesthetic required. Now, disadvantage, they can depress respiration, they cause pinpoint pupil, but decrease the size of pupil. So, assessment of the pupillary size to assess the depth of anesthesia may be hampered. So, interfere with pupillary sign, may cause fall in blood pressure during anesthesia, can precipitate asthma, so should be avoided, can precipitate asthma and tend to delay recovery. Lack of amnesia, flushing, they can delay gastric emptying, so risk of aspiration pneumonia. Biliary spasm, post-operative constipation, vomiting and urinary retention. Tachycardia can be seen with pethidine. Use of opioid is now restricted because of to those having preoperative pain. Fentanyl, because of shorter action, they are used intravenously just before induction. The third group of drug, anticholinergics. Anticholinergic ki laab? They will dry up the respiratory secretion. So, atropine or hyoscine or glycopyrrolate, they have been used primarily to reduce the salivary and bronchial secretion. The need is infrequent nowadays because lesser irritant general anesthetic agents are used nowadays. The main aim is to prevent vagal bradycardia and hypotension and prophylaxis of the laryngospasm. Hyoscine problem ta ki ache? They can cause basically they can cause disorientation and emergence delirium. Now glycopyrrolate. Glycopyrrolate is one of the antihistaminic that does not cross the blood-brain barrier. So CNS toxicity can be prevented. So it is twice as potent and longer acting quaternary antimuscarinic agent which does not produce central effect. Anti-secretory action is more prominent than atropine, while tachycardia is less marked. They are the preferred antimuscarinic in the anesthesia practice. Now there is a comparison between atropine and glycopyrrolate. Anti-secretory action is higher. With glycopyrrolate, tachycardia is lower. CNS effect is not there, unlike atropine. Bronchodilation same for both the drugs. Now they facilitate assisted ventilation, but there is increase in the anatomic dead space. Number one problem, disadvantage. Number two, they dilate pupil, so pupillary assessment can be done. Number three, they increases the chance of gastric reflux by decreasing the tone of LES, lower esophageal sphincter. Then they should not be used in febrile patient because anticholinergic can cause fever. Dryness of mouth in the pre and post operative period may be distressing, and they are now mostly used intravenously, intraoperatively when need arise, not in all cases. Neuroleptics not used nowadays. Chlorpromazine, triflupromazine and basically haloperidol, they are infrequently used. LA anxiety, smoothen induction have antiemetic action. Problem, potentiate respiratory depression and they can cause increase in the muscle tone. So hypotension, delay recovery, involuntary movement and muscle dystonias, especially in children. H2 blockers, proton pump inhibitors, they are basically important in case of prolonged operations in the cesarean section and obese patient. Why? Because of the risk of the gastric regurgitation and aspiration pneumonia. Ranitidine, famotidine, omeprazole, pantoprazole, these are the drugs that are used a night before, at the night before the operation, in the morning of the operation. And how they act? They raise the pH of gastric juice and they also reduce the volume of gastric secretion. The chances of reflux and damage to lung on aspiration is minimal if volume of gastric juice is less than 25 ml and pH more than 3.5. Prevention of stress ulcer is also one of the advantages of the use of H2 blockers or PPI. They are now routinely used before the prolonged surgery. And lastly, antiemetics like metoclopramide, they reduce post-operative vomiting. How? By increasing the tone of LES. They reduces the chance of reflux and aspiration. Problem with metoclopramide, extrapyramidal side effects, muscle dystonia. So extrapyramidal effects and motor restlessness can occur. Combined use of metoclopramide and H2 blockers is more effective. Then comes the domperidone, nearly as effective as metoclopramide, but extrapyramidal side effects are not there. And lastly, ondansetron is a selective 5-HT3 receptor blocker. Now, they are highly effective in reducing the incidence of post-anesthetic nausea and vomiting. No side effects, no bole cholbe na, very few side effects, and so they are the antiemetic of choice in anesthetic practice. So pre-anesthetic medication e ki drug use kora jay? What do we mean by pre-anesthetic medication? কে বলবে? These are the drugs used prior to give anesthesia, so that anesthesia can be given smoothly, or the induction of anesthesia may be smooth, less distressing to the patient and safe. What are the drugs? The aims of pre-anesthetic medication, ওটা 5-6 পয়েন্ট পড়ে নিও, পরীক্ষাতে আসতে পারে। What are the drugs used? হ্যাঁ, সরি, অ্যান্টি-এমেটিক দেখা যাচ্ছে। হ্যাঁ, অ্যান্টি-অ্যাংজাইটি, very good, very good. These are the commonly used nowadays. হ্যাঁ, then আর কি ইউজ করা যেতে পারে রে? Opioids. আর anticholinergics, particularly glycopyrrolate is used. আর neuroleptics not used nowadays, rarely used. ঠিক আছে, বসিয়ারে। আচ্ছা, তোর গ্লাইকোপাইরোলেট অ্যাডভান্টেজটা কি আছে? একটা কোয়েশ্চেন লাস্ট ইয়ারে ছিল ইন্টারনাল এক্সামে। তো হোয়াট ইজ প্রি অ্যানেস্থেটিক মেডিকেশন, হোয়াট আর দ্য ড্রাগ ইউজড অ্যান্ড দেয়ার র্যাশনালিটি, কেন ইউজ করা হয়? লাইক বেনজোডাইজিপিন কেন ইউজ করা হয়? হ্যাঁ, অ্যালি অ্যাংজাইটি। আর smooth induction of the anesthetic agent. আর loss of recall of perioperative events, amnesia. হ্যাঁ, ওটার জন্যই। আর ওপিয়েড কেন ইউজ করা হয়? কি কি ওপিয়েড ইউজ করা হয়? মরফিন, পেথিডিন, ফেন্টানিল, এই তো। কেন ইউজ করা হয়? গ্লাইকোপাইরোলেটে কি অ্যাডভান্টেজ রয়েছে ওভার আদার তোর অ্যান্টিকোলিনার্জিক্স? They does not cross blood-brain barrier, so CNS effect will be low, tachycardia less common.